We're going to start again. And we get to start with, we're going to do it in reverse order this afternoon. We're going to start with Allison Hoffman from the University of Pennsylvania, who's going to be a little bit more general. And then we're going to go to Charlene Harrington from UCSF. And like the previous times, we're going to hold questions until the end of both of their presentations, and then we'll have a chance to participate in some discussion. So join me in welcoming loudly Allison Hoffman, please.
Thank you. It's a pleasure to be here today. I'm going to. Thank you. I'm gonna start with not that close. A basic premise that I suspect most people in this room will agree with, and then I'm going to make a conceptual case for it. So my basic premise is that any successful Medicare for All plan should include comprehensive coverage for long-term care. I suspected that was the case. And what I'm going to spend my talk today focusing on is what is comprehensive coverage, and if we think about how can we think about conceptually long-term care in a way that is going to make a comprehensive policy solution more likely. So if we simplify the concept of insurance, we all pay into a common pool, and those of us who need goods or services are covered by insurance and have things reimbursed that we need. The decision, when we decide to include a benefit, to include something in an insurance pool, it makes risks of harms, risks of needing medical care, spending money on that care. It makes those things collectively felt rather than individually felt. And so far what we've done is we've largely left long-term care out of public insurance like Medicare and Medicaid, and private insurance hasn't worked. And as a result, what that means is that the risks that people face when they have long-term care needs or when they're helping others with long-term care needs are borne privately rather than collectively. So when we think about what insurance for long-term care could and should accomplish, what I want to suggest is that if we shift the way we think about that, the potential for long-term care insurance, it will help us make a solution more comprehensive and more likely. I suggest that we reimagine the risk of long-term care. So let me explain what I mean by that. As a society, as we've thought about long-term care, we have thought about it, conceived of it primarily as the risk of having a chronic illness or disability serious enough to require sustained care. And I call this care recipient risk. When people face this risk, what they need is they need to obtain care supports. If those supports are too expensive, it can cause somebody financial insecurity, or if she gets the wrong or insufficient supports, she can face health insecurity. It's a risk faced by 10 million people, half of whom are over age 65 and half of whom are under age 65. So we often think about it as an aging problem, but it's not just that. Now, what I want to ask is, what if we look at the same problem from the perspective of the friends and family who become responsible for helping to provide care for people who need it? Any one of us could, not all of us will, become responsible for intensive care for a child with a serious disability, an ill or injured spouse or partner, or an ailing parent at some point in our lives. I call this the next friend risk. Next friend is a legal term for somebody who stands up in court for somebody else who can't do so for themselves. And I like this term because of its neutrality. It doesn't imply that the next friend is family. It may not be. It is often friends or other people in the community who help provide this care. And it also does not imply that the next friend is actually the one who does the caregiving. Using the term caregiver or informal caregiver implies that. The next friend might help by arranging care or paying for care, or in all kinds of ways. So in the next 10 minutes, what I want to do is three things. First, I want to critique how our current policies and insurance design have conceived of the problem of long-term care too narrowly. Second, I'll tease out this concept of next friend risk and argue why we should consider this risk on par with care recipient risk. And then finally, I'll think about the difficulties. If you pull the lens out in this kind of way, and I'll talk about some of the objections and concerns. So Medicaid by default, this is the current conception of how we think about long-term care. Medicaid has shaped how we think about long-term care and what insurance should do about it. Medicaid has become the largest, the main payer for long-term care by default. And as such, it has tremendous influence over how we structure long-term care in this country. Medicaid has, in fact, reinforced obligations for friends and family to provide long-term care informally, usually without pay, by providing incomplete coverage for the caregiving needs of people. It is, by design, it is not intended to be comprehensive for the population. It leaves gaps. So it's not universal like Medicare for All would be. It's means tested, it is meager, and what that means is it leaves many people with no insurance, no coverage at all until they spend down their resources to qualify. And then even more, when people have Medicaid coverage for long-term care, they often find it doesn't provide what they need. And if you think about why that is, if you rewind to the very beginnings of the creation of Medicare and Medicaid, they were not programs that prioritized thinking about caregiving. As the social welfare programs developed in the United States, how they thought about the core of what they should do was to protect against things that posed a threat to household or family wages. And so that's kind of what brought things into the fore of policymaking. Caregiving didn't pose a threat at the time when most households had a non-wage earning spouse, usually a wife, at home. And so what we see as a result are, you can see this throughout all of our policies, but when we think about long-term care policy, we see things like personal care services are an optional Medicaid benefit rather than a mandatory Medicaid benefit. And so that means that states may, but they don't have to cover personal care aspects of long-term care, things like feeding or bathing or transferring. Even more so, when you think about, if you go back to the actual drafting of Medicaid, it was modeled after the Kerr-Mills Act, which was influenced by notions of private insurance. And what private insurance did and the Kerr-Mills Act did was it paid for medically insurable harms. And typically that meant that services had to be provided by licensed providers and in licensed facilities, which excluded many of the caregiving aspects of long-term care, especially when they were happening at home. So Medicaid was designed in a way that by its very structure prioritized medical care over caregiving, and then structurally cemented this reliance on friends and family for caregiving. Now what we're seeing recently is that this reliance is increasing, and it's increasing with a significant shift to home-based long-term care. Medicaid initially had what is called an institutional bias. It paid for long-term care primarily in nursing homes and other facilities. Medicaid policies have evolved over the last few decades, motivated in part by legal obligations to pay for long-term care supports in what is called the least restrictive setting possible, which in many cases means at home. And so the result of that has been this. So what you're looking at here is that a growing percentage of Medicare dollars are now spent on home and community-based services, 57%. So this slide shows the dramatic change in Medicaid funding for long-term care in the past 20 years. The gray line going upward is the spending on home and community-based services. The green line going downward is the spending on institutional long-term services and supports. This trend is, of course, a success story in some ways. People with chronic illness and disability can live at home as independently as possible. But structurally, it can be quite difficult to fund 24/7 supports in home settings, and Medicaid has not met the demand, resulting in limits on services and long waiting lists for home and community-based services. As a result, people increasingly are relying on friends and family to provide care, and typically without pay, this informal care, or they pay for it on their own if they can. So this is the picture of what we have today, and what I want to ask is, what if we could reimagine this problem from the perspective of the next friends who are coming in and providing these supports for loved ones? How would that change the way we think about solving the problem? About 40 million people. So what does this obligation look like? About 40 million people provide some level of informal long-term care today, ranging from an hour or two a week to around the clock. Although families have long provided care, this notion of care as a private obligation is becoming untenable in a changing world. That breadwinner family structure that I was talking about is gone. There's no one in the home, in most homes, who can be fully dedicated to caregiving. There's an increasing number of women in paid jobs. The number of two-wage earner or single-family parents is increasing, and families are dispersing geographically. The ratio of people needing care to people who can provide it is growing, and with medical and technological advancements, we're keeping people alive longer, and also needing more supports. As a result, the costs associated with informal care are quite high. It is hard to define exactly what this cost is, and it's hard even to think about it descriptively. How do we think about these costs and to measure them empirically? But a number of studies have indeed attempted to do this. And we get estimates like a widely relied on study that says the average adult child who leaves the workforce to care for a parent experiences about $300,000 in economic loss from lost wages, lost pension, lost Social Security, lost benefits, lost advancement. Estimates for this range from about $200,000 to $600,000 in other studies. Studies have measured the non-economic harms to their health, their well-being, their relationships, including disproportionately high rates of depression among informal caregivers. And part of what concerns me is really not measurable at all. It's the fact that providing long-term care absorbs somebody's time and money in a way that clearly impedes their life's choices and their ability to live their own lives in a way that is quite difficult to quantify. So what I contend is that we should think about these losses, about these costs, this responsibility for another's long-term care as a life cycle risk, and an insurable one, in fact. It's near universal, it's unpredictable, and when considered from the perspective of the next friend, it's uncontrollable in most cases. Even if people take on, which many people do, many of you I'm sure have, take on caregiving roles with great generosity and love, they face significant insecurity in doing so. We haven't thought about this insecurity as an insurable risk, in part because it is hidden from the public eye and the balance sheets. It happens in homes and where it is hard to measure. But we could come to think about this risk as insurable and as serious as the risk of needing care from the care recipient perspective. So why should we do that? Considering next friend risks helps us understand the problem of long-term care in 4 ways that I think make an effective solution more likely. The first thing it does is it redefines the scale of the problem. Now, it makes it larger, which is challenging in some ways, which I'll talk about in a moment, but it makes it more realistic as well. So current estimates of long-term care costs hide these costs that are borne by next friends. I call them thus the invisible co-payment. This is what people are paying through their time and their spending towards the lack of insurance in this space. By conservative estimate, it's over $500 billion, twice the amount of current funding for long-term care. Seeing these costs clearly can help us more realistically think about what it would take to solve this challenge. The second thing is that reframing it as a risk, thinking about this as next friend risk rather than as obligation, implies that insurance is indeed the solution. Since very few people can afford to self-insure or privately insure for long-term care, it means that public insurance is the solution. And understanding it as a universal risk, one that we all face, could help build broad political coalitions that actually want to solve this problem. The third point is that considering this next friend perspective suggests that long-term care insurance could be designed in a way, the policy design could be more sensitive to the harms experienced by next friends. Understanding these harms as the result of risk instead of as personal obligation to care for somebody else makes clear that there are 2 legitimate ways that someone could, in theory, respond to a loved one's need for care. They could provide that care, or they could arrange or pay for that care. And at the very minimum, policies should be designed in a way that is more neutral between these options, rather than, as is the case in many programs today, biasing towards the family providing care and then providing some minimal supports for them, perhaps in the best case scenarios when they do so. So I call this the toggle, and I think we need to design policies, even in existing programs, that allow people to toggle between these options so that if they do have insurance coverage, they could just as easily use it to provide the care as they could to pay somebody else to provide the care. If the benefits allowed recipients to toggle freely between these two spaces, the next friends could consider how to use benefits to minimize their own potential insecurity and to balance those considerations with the needs and the wants of their loved ones. The current policies are so focused on care recipient risks that they don't even see the need for this toggle, and often impede movement between these two choices. So the last point is that seeing next friend risk, it forces an admittedly uncomfortable question of whether social insurance policies should make different trade-offs than they do today between mitigating care recipient and next friend risk. So consider the example of an elderly widower who has a stroke. The goal of the current long-term care policy under Medicaid is to ensure him adequate care supports in the least restrictive settings possible to protect his autonomy. So if his daughter moves him into her home, his needs could be fully met at the lowest possible public cost, but the daughter's cost may be high. The daughter may have to reduce working hours or leave a secure job with benefits, threatening her family's long-term finances. It may disrupt her other obligations, relationships, health, and well-being. If next friend risk were taken seriously, social policy would be structured to better balance the needs and the autonomy of both of the parties, even if it means a solution in some cases that is second best for the care recipient. So far, what I've covered is why we could think about the responsibility for another's long-term care as a risk. Here is why we should. First, it could mitigate a serious threat to the security of American families, to protect against these kinds of life cycle risks that we use social insurance to do. Second, these harms are disparately experienced. Over 60% of caregivers are women. Informal caregivers are women. It's more common in certain minority communities and in low-income households. Underinvestment in this area, the fact that our social insurance does not put dollars into this now, has depleted both physical and human capital. It has eroded good care infrastructure. So lack of financing has thwarted innovation in this space, and it has dried up the growth of labor supply of people who want to do this work. And it also means that the people who do this work are currently underpaid. So a funding infusion could reverse this trend. And then finally, additional funding, along with good policies that have a toggle, could, I think, have a long-term sociological impact. If next friends are able to work with their loved ones to define combinations of paying for care and providing it that best meet their needs, long-term care policies could help reshape our conceptions of what it means to be a good son or a good daughter. The good daughter or the good son might not be the one who takes mom into their home, but it may be the one who helps her figure out how to best meet everybody's needs. So I'm out of time, but let me just spend one moment on challenges. There are clearly challenges if we think about the problem from this perspective, but they are not insurmountable. There are demonstration programs in the US, there are comprehensive long-term care policy solutions in other countries that show lots of different ways that long-term care policy can be effective. Let me focus just for the last moments on the concern that I'm sure some of you are thinking about. That is, if we include the invisible copayment in the total cost of long-term care, it becomes a bigger problem. So if we think about it, if all we do is monetize the current unpaid informal care rates, the hours that people spend now, at the rates of average caregiver compensation, which is arguably too low, then we triple the size of the problem. So this size may at first blush suggest that solving this problem is not solvable, that solving the problem, if you think about it in this broader way, is impossible or that if we try to include it in some kind of Medicare for All proposal, that it would sink that proposal by making it, by adding dollars onto what Bob was showing us earlier, that make it even more challenging to solve. But I think that that's the wrong way to think about it. A failure to address this problem isn't making these costs go away. One study suggests that the aggregate cost to baby boomers who are now caring for their parents, and this is only a sliver of the long-term care story, is about $3 trillion. Our current approach is reinforcing a system where these costs are borne privately. The results are inefficient, they're inequitable, and they are going to be felt for decades to come. Including long-term care would not only remedy these problems, but it might be helpful in building new coalitions for action. I think it is useful to include an accurate version of how we think about the costs of long-term care, both to design reform as we're thinking about fundamental reform in a way that truly does provide people long-term security, and that also gets as many people as possible to understand the scope of what it takes to do so. I think a lot of people do deeply care about this problem and may engage with Medicare for All policy if this is one of the many issues that is discussed as part of it. Thank you.
Thank you very much. I'm going to be using the word long-term services and supports, or LTSS, since this is the new term that disability advocates like us to use, and it takes some of the emphasis away from care and puts it more on the supports activities. So I think Allison has made an excellent argument for why we need LTSS coverage. Of course, about 70% of the population is going to need LTSS at some point, and it's quite expensive when you add up the overall lifetime cost. And we know from studies that the average retirement of money or savings that people have is definitely not adequate to cover the cost of LTSS. And private insurance, long-term care insurance it's been very expensive and very few people have it. And as Allison mentioned, the burden of caregiving to children is a huge cost to them and to society in terms of lost wages, pensions, and social security. So as we know, Medicare only pays for short-term, what we call short-term nursing home and home health care, up to about 100 days of care. So most individuals have to pay for this care directly out of pocket unless they're poor and eligible for the Medicaid program, or they have to spend down and become poor in order to get services. I'm very excited about the new House Bill 1384 because it does have long-term care provisions in it, and it has a very broad base of LTSS for all ages and all disability groups. And it prioritizes home and community-based care over institutional care and care in the least restrictive environments, the most integrative settings. And it supports what disability advocates want, which is increased ability to be involved in civic, social, and economic activities, and allows for independence. HR 1384 also recognizes that there are quality problems with the long-term care that's currently available and huge inequities in services across regions and states. So one of the goals is to ensure equity in quality and accessibility. And also it puts a strong emphasis on letting individuals direct their own LTSS services and have personal care workers. And it has a broad-based advisory group. The big problem with long-term care, of course, is the cost. And that's why everyone is worried about including long-term care in any kind of national health program. In 2020, it's estimated that the country is spending $510 billion on long-term care, which is about 15% of all personal care services. And this is for nursing homes, residential care, home health care, and other health and personal care services. So one of the issues is, can we afford to pay for all of the care? But as you can see, we're already paying for a lot of LTSS services. Only 13% of formal LTSS services is out of pocket. So in theory, we would have to cover that 13%, which would be $68 billion. So some people argue that we need to try to save costs, so we should just pay for the front-end coverage. But of course, I don't think that makes sense because we already have Medicare that basically pays for the first coverage. And other people say we should just pay for catastrophic coverage after the costs get to be too much. And basically, that's what Medicaid does once you spend down. So it's all the in-between costs that people are paying out of pocket that I think we should pay for. Of course, we all know that the risk of needing long-term care goes up as the population ages. And as was mentioned, about half of the people with disabilities are under age 65. So I think it's important to include all groups the way 1384 does. So then the next argument becomes how many people need LTSS. And the bars on the left are from different national surveys that estimate how many people live in the community, and the ones on the right are how many people use LTSS in institutions. So we know we have about 2 million people living in institutions, and these estimates, if you include everyone with a disability, although they're a little bit old, would be 11 million people. So overall, about 13 million people need services. One of the things about HR 1384 is that it's written in that it would pay for services for people that need one or more activities of daily living. And that activities of daily living include bathing, dressing, toileting, transferring, and eating, or one or more activities of what we call IADLs. These are activities such as help with walking, shopping, paying bills, and participating in the community. So this is a rather generous benefit. And so one way to cut costs might be to go to 2 ADLs or more, and then that would bring the number of people that need services down to around 3 million. But as was mentioned by Allison, most of the long-term care services are provided by unpaid caregivers and friends and family members. Only 13% of care that's given at home is paid care that's paid for primarily by Medicaid. So this means that we would have to come up with care that the care at home is equivalent to, say, 30 to 40 billion hours of care. That's a lot of care. And so this is what the economists worry about, because if we offer this benefit, then people are going to want the unpaid care that they deliver now to be covered by a national health program. So we need to think about design features that will support people at home so that we still can help unpaid caregivers stay and continue to help, but be able to give them enough support to make the caregiving possible. So another policy issue that we have to think about is the poor quality of care provided by some formal care providers. Particularly, everyone's familiar with the nursing home problems of quality, and this is also true with some of the home health and the hospice care. So most of the long-term care providers, institutions and agencies are for-profit. And so the care is poor, and that's compounded by the fact that we pay very low wages and benefits to individuals that deliver the care, at least 15% below what they would make in the hospital sector. So I think cost would increase if we were going to pay reasonable wages and benefits to stabilize the workforce and keep people in the workforce, and also to increase the staffing so that we would have adequate staffing levels in nursing homes and agencies. And there would be some cost savings from this, because we know, like right now, about 22% of nursing home residents end up back in the hospital, and the cost of rehospitalization is billions of dollars, and emergency room use. So then there would also be potential cost savings from reducing the administrative costs and the profits, which tend to range, around 20 to 30% in the long-term care sector. So in summary, the policy issues are whether we should include everyone or just part of the people that need LTSS, and then what kind of LTSS coverage we should have. Should it be like, is the AB 1384, HR, 1384, should it include preventive services, home and community-based services, and a full range of coverage, or should it be limited to just front-end or back-end coverage? And then there's the issue of, what should the eligibility be, and then how much do we want to invest in trying to improve the quality, and how much savings could we obtain? And of course, we certainly want to ensure equity across all of the states and all of the regions. Right now, as many of you know, the Medicaid program is grossly inequitable by state and regions because some states put very little money into it. And then finally, what kind of profits and administrative cost controls can we adopt? So I'll stop there. So thank you.
Well, thank you very, very much to both Charlene and Allison. And we have a few minutes for questions. So if we have our microphone runners to help. Jim, you've got one right in front of you. If maybe you could also help right here. We've got some questions. Do you have a pencil or pen? Can you, if we take a couple? Yeah. No, excuse me. You have a pen.
Can you hear me now? Okay. So I'm a registered nurse. I've worked in healthcare for 45 years. I've worked with the elderly and frail for many years. I've also worked as a surveyor for the Centers for Medicare Services in these nursing homes and long-term care facilities. So one question I have there been any studies done that correlate the cost of providing the LTSS coverage in the home versus long-term care facilities? And then I have one more question after you answer that.
No, I'm going to take a few questions, so go ahead and ask your next question too, if you would.
So my second question is there any provision in what you're forecasting for the coverage for education for these in-home caregivers? As a hospice nurse, I see many patients who want to be taken care of at home. That is their choice. But the bottom line is their families do not know how to care for them at home. And that presents serious quality of life and quality of care issues in the home. So has there been any thought to, I understand at this point there's no type of reimbursement for educating caregivers in the home.
Thank you so much. Let's take a couple more questions and then we'll get a consolidated response, please.
Hi, my name's Carey. I'm an MBA, MPH student here at Berkeley, and my question is, what can we learn from other countries who are experiencing similar high aging populations, decreasing growth, et cetera?
Great. One more back there.
Hi, my name is Millie Bronstein with Healthcare for All California. And my question is really an economic study one. With the House bill, Jerry Powell's bill, and with our single payer proposals, we're building in a whole different kind of quality system where we are going to value preventive care. And so that there's nothing talked about here now on, we have some current costs, but not looking at what projected costs would be if people have access to wellness care rather than sick care and throughout the lifetime, so that we're talking about populations that will need service from birth to death who may be born with a disability versus we're focusing right now, it seems like, mostly on the aged population, but we also have a large number of people that are with disabilities that are younger. And so I would urge some cost studies reports, because there should be a lot of savings if you focus on wellness care.
Thank you. And one last question right next to you there. Just you can pass the mic. Thank you.
Margaret Copy. I'm a psychiatrist, and I work with a number of organizations. I've been a PNHP member since I was a medical student. My question has to do with 1384 and whether it, like the PNHP proposal, would ban for-profit nursing homes along with for-profit hospitals and renal centers.
Thank you. So you can bounce it back and forth, but who wants to go first? Allison?
Sure. On the question of costs of providing in-home care versus long-term facility care, if you look back at the beginning of this shift towards home and community-based services, the shift grew out of a case called Olmstead, and the Olmstead case was brought by there were a number of cases at the same time, litigation that was brought by two coalitions together. It was the disability rights advocates, the civil rights community, and it was the budgetary hawks who were together, kind of these strange bedfellows bringing this litigation forward, because moving care from institutions into home would serve very different purposes at the same time. And so I don't know if I've seen like an actual quantification of what we would spend differently if care happened like as it did 30 years ago. But I have seen like there are studies that shows that something like 500 to 700,000 more people would be in institutional care today than are. And that suggests just because of the cost of institutional care that the cost would be much higher. I haven't seen an exact quantification of that, but I think that's, you know, I'm fairly confident that we spend less today than we would if we had a different balance of home-based care and institutional care. The question on whether also, it's interesting, a number of you asked questions about costs, and the questions of if we shifted more towards a wellness system than a sickness system, what would it look like? And the truth is that people would, whatever system you were in, would eventually get sick and would die. And that last phase of life, even if you shift it, which ideally you do, right, is you create more quality number of years and you shift that down the road, and it still happens. And so you can't really escape this problem. What is an interesting thing is that we're seeing a kind of a shift in the way we think about those last years in this country now, and we're seeing, you know, the death panels of the Affordable Care Act are now law. We now pay for that kind of end of life counseling in the Medicare program, and we see palliative care gaining more prominence and being talked about more and being tested more than we had before. So there is a real question about whether we would do the end of life differently if we thought about kind of what it means to die differently in ways that could both be better for people in terms of what they experience at the end of their life, what their families experience, and could also conveniently be cost saving as well.
Okay. In terms of the question about the costs, potential cost savings, at UCSF, we have done a number of research studies showing, particularly focused on the Medicaid population, comparing institutional services with home and community-based services. And we know that we see a savings with the home and community-based services. And generally, people are happier with their services and think they're better quality. Although, of course, there's always going to be a need for some institutional services. In terms of the issue around training, some states do offer training programs for caregivers at home and pay for the training programs, and that could be expanded. But in terms of training workers that are currently in the workforce, it's very important, but the workforce is so unstable right now because of the low pay, the low benefits, and the heavy burden of the work that there's high turnover. So it's I think we need to stabilize the workforce first, and then you can do reasonable training programs. And of course, I think we're running out of time, but on the question of other countries, I particularly like the German system. There's been a lot written on the long-term care mandatory coverage in Germany, and Germany gives families the option of institutional care or home-based care. And if family caregivers are providing the care at home, the German system actually pays for the pensions. And Germany has been able to keep its cost within a reasonable level. I think they've had to increase it just once, but not by very much. Okay, I think.
Can I say one more thought quickly on what can we learn from other countries? I think the main thing we can learn from other countries is that this is doable because many do it, and also that you have to make careful policy decisions about what you cover and exactly how you design the policies. So the German, just to take the German example for a moment, one of the things that countries have to think about is if you take benefits in kind versus in cash, are they equivalent or not? And if one of them is more valuable than the other, how does that affect how people decide how they're going to meet their care needs? How does that shape people's decisions around these kinds of things? And different countries have done that in different ways. So even the most nuanced pieces of policy designs can have tremendous sociological and kind of interfamilial effects. So I think we can learn a lot on kind of the global level that this is something that should be in any kind of Medicare for all bill, and that we have to be careful when we start to design policy around it.
Well, listen, before I thank the panelists, I just want to invite the next panel to come up because we're over time. And I want a big round of applause for two very interesting panelists.